Thank you very much, moderators. It's a great pleasure to give this talk. I was asked to give my 20-year experience on doing cryotherapy tips and tricks, and 20 years. I can't really believe it's 20 years. It's hard to imagine because I'm only 25, so I don't understand how that could be. I must have been doing cryotherapy when I was in kindergarten. But I continue to do cryotherapy every week. In fact, I try to do, on Thursdays, I try to do 5. We do 5 by 5. That's what I tell my OR staff. And it's still the best day of the week. And I have enjoyed doing cryotherapy, and I've enjoyed evaluating the patients preoperatively. I still enjoy doing the procedure intraoperatively. It's a lot of fun to do, and taking care of the patients postoperatively. And I continue to hear patients that I've treated many years ago that come to me 15 years later, 20 years later, that say, you know, Dr. Katz, remember when I was first diagnosed with prostate cancer and they told me that I have a radical prostatectomy or radiation therapy, and you did this freeze procedure on me back then, and I'm still doing great. Or I recently, I know this is an anecdotal thing, but I recently, just about a week ago, got a letter from a patient of mine that was young at the time when he had seed therapy. He was in his early 50s, and then he relapsed at 60. He's now 75, and he wrote me a letter that he was able to go to his granddaughter's high school graduation. So touching, and a lot of great stories and a lot of great experience doing the technology. Let me just get a show of hands in the audience who actually has had some experience with cryotherapy. Okay, so that's pretty good, about half. I remember when there were days when I was up here and there was no one that had any experience at all doing it. And in 2001, I was very instrumental in helping Medicare and CMS get this approved, both on the primary and on the salvage. And today, when I schedule a patient, I basically have 4 procedures that I do for cryotherapy. It's either going to be a primary cryo total or a primary focal, or a salvage total or a salvage focal. So let me just tell you some of the things that I feel are important if you're considering these patients for cryotherapy. Key, is, like any other procedure, is patient selection and being just very transparent with your patients. In terms of total primary cryotherapy, obviously I'm going to pick patients that are not low risk, that are going to be either intermediate or high risk patients. And I've always been impressed throughout my career that cryotherapy can ablate high risk disease with no evidence of metastatic disease. So you want to do a metastatic survey, that the patients should be counseled for radiation therapy or surgery. And I feel the majority of these patients are either do not want to have radiation, they've had radiation for other, maybe testicular cancer, colon cancer, they have bilateral hip replacements, they can't have radiation therapy. I get a lot of referrals from my radiation colleagues for that, or they're just not candidates. They should not be concerned, and I'll tell you, about sexual function. If you do a total primary where you're taking the ice out into the neurovascular bundles, sexual function should not be a concern for these patients. And in my own experience, Viagra doesn't really seem to help, Cialis doesn't seem to help, young girlfriend doesn't seem to help. The only thing that really seems to help is either intracavernosal injection or penile implant. And then I think that unlike radiation therapy, we're using androgen deprivation therapy for 18 months or 2 years or longer than that. I do use androgen deprivation therapy, but minimal, usually less than 6 months for the high-risk patients. And the patients should be able to tolerate at least an hour of spinal anesthesia or general anesthesia. For the focal, obviously a major focus here in this meeting is patients that have biopsy-proven low to intermediate risk disease, unilateral cancer. I like that the MRI matches up with the biopsy if there's concern. If obviously there's another PIRAD, I always get an MRI on these patients, even if they come in with saturation biopsies, because it's PIRADs, MRIs can miss it, biopsies can miss it and can be detected on MRI. So you really want to make sure that the MRI and the biopsies match up, and you want to make sure that the patient has a clear understanding of other options when you're offering them focal therapy, like active surveillance, because many of these patients are low to intermediate risk. They're good candidates for active surveillance or radical prostatectomy or radiation therapy. Preoperatively, I think that it's very important, especially if you're going to do this procedure in a whole gland situation, that you need to know the size. Size matters. You don't want to do this if it's a 120 or 130 gram gland. It just won't work. You won't be able to ablate the entire gland. And if you try to, you'll end up with a patient with significant urethral comorbidities. You want to exclude those patients with large TERP defects, because the urethral warmer won't be able to co-opt against the walls of the warmer, and you'll wind up with sloughing. And like other talks that we heard about this morning, beware of the calcified gland. This brachytherapy patients, if you're going to do this on seed patients that have failed, which I've done a lot of those patients, it's best to do the entire procedure in the sagittal view, because if you look at it in the transverse view, it looks like a whole, you can't see it. It looks like calcifications in the seeds, and you can't see it, and you can't distinguish between the seed and the needle. So you'll need to do the procedure entirely in the sagittal view, and then it's fine. Intraoperatively, I use preoperative antibiotics. I've always used gentamicin and flagyl, and I'll tell you that, I don't know, I can't remember a single patient in my last probably 3,000 patients that I've actually had a urinary tract infection. I had not admitted any patients. You need to have the proper ultrasound set up. This is the typical view that we have here. Initially, you want to make sure that the bladder is well distended so you can see the bladder and you can see the prostate. And the device that I've been using, both systems that are commercially available in the United States have thermocouple devices, whether they're multi-thermal sensor devices or whether they have, but you want to make sure that you use the thermocouple devices, especially in the area of the tumor as well as in the external sphincter. And if you're trying to preserve the neurovascular bundle on that side, that you have a thermocouple device there. Make sure you use them, and make sure that the thermocouple device is placed in the external sphincter, especially in the small radiated prostates. You place the external sphincter device, and then you do your cystoscopy, and you can see the thermocouple device as you wiggle it, and you can make sure that it's properly placed in the external sphincter. If your temperature in the external sphincter stays above 20, I guarantee you all your patients will be continent. And these are in the post-radiated, even in the smaller glands. And this is what the glial system looks like. This is, I'm doing a right focal ablation. You can see the temperatures. I like the temperatures to drop in all the thermocouples except for that green bar that's going on the top there. This is the external sphincter line, but you can see these are the temperatures in the gland and in the area of the tumor, and they're dropping down below -80. I definitely like the temperatures to go below -40, and I'm satisfied if they go down to -80 or below. You bring the patient into the operating room, you place a Foley catheter, you do your ultrasound, you distend the bladder with usually 300 cc's of sterile water. Then you insert your needles and thermocouple devices, one in the external sphincter. You do your cystoscopy to make sure that there was no inadvertent injury to the urethra.
Yeah.
I think it's key that, have I gone over time?
Yeah.
Okay. I think it's key that you do the cystoscopy. You also need to do a double freeze thaw cycle. There'll be a discussion about not using a urethral warmer in a focal manner. I encourage you to all use the urethral warmer. I do it in every case, and I have not had any sloughing. The patient goes to the recovery room, and the patient goes home. You need to make sure that the ice ball is brought down all the way down onto the anterior rectal wall, and you can bring. This is an example of it. You see. You need to bring the ice ball below the capsule of the prostate, because this is not lethal ice. This is only about 0 degrees. You need to make sure that that ice ball goes below the capsule to ensure that that peripheral zone is ablated and killed. And it's okay to bring the ice ball down onto the rectum, and and place a Foley catheter for a few nights, get your PSAs every 3 months, and if the patient is concerned, especially a focal for sexual function, make sure that you use daily Cialis. I won't go into my talk, but some of the other conclusions. But I wanted to let you know that I think focal therapy is an excellent quality of life, excellent cancer control. It's relatively easy to do if you do an ultrasound in your practice. I've had a wonderful experience in my career doing this. I continue to do it, and as I said, it's the best day of my week. Thank you very much.
Thank you.